probably 3. So yeah, there's a bunch of us in here. So we're gonna break up into groups of 3. Make sure there's someone in your group who was in the talk. So who was in the talk? Okay, so if you were in the talk, find 1 or 2 people who weren't in the talk. Okay, so get into your little groups. Who needs a group? Make sure there's at least 1 person in your group who was in the talk. That's with your groups of 3. Okay, perfect. We have someone over here. You guys need a group? Anyone need a group? They were in the talk. And you can have more than 1 person than that in the talk. Perfect. All right, good. All right, so you got your little group. Okay, so what I want you to do, just for like no more than 5 minutes, if you were in the talk, I want you to kind of give your summary. I know. Give your summary of what you heard to the people who weren't in the talk without judgment. Let's not judge those that weren't there. I'm just kidding. There's so many good people. I know. So give a little summary. And then I also want you to grab, hopefully you all have backpacks or something. Someone be the secretary of your group. And you're going to grab a piece of paper and a pen. And I want the group to just come up with 2 questions about back pain, a patient that you're working with, something along those lines. Because I'm going to assume who in here works with clients with back pain. I figured all of you, since that's why you're here. So you probably have someone in your head right now that you're thinking about, that you're like, I am coming to this talk because I want to try to understand this person more, or I want to learn this more. I don't understand what to do with this patient more, or this client, right? Like that's kind of why you're here. You want to understand something better about back pain. Because back pain is so multifactorial. There's so many different things. And what happens is then I end up, at the end of the night, answering all the individual patient questions that you all have, which is fine, I'm happy to do that. But you all have similar patients that I think we can all kind of learn from. So what I want to do is just take about 5 minutes, just summarize what we talked about, and then just come up with 2 questions based on patients that you have, people that you're dealing with, clients that you have, that you want to leave here. You guys have me for the next 70 minutes. I want to make sure you leave here with the information that you want. I can put you through a workout. I'm going to show you a couple of things that I like to do with this stuff as well. But I want you to get what you want out of this, right? Like this is your time. This is going to be the most intimate time that you have with me for probably the next year. When I come back and see you guys next year. So let's just make sure you get what you want out of the session. So just take 5 minutes and do that for me. Go ahead.
How are you? What's your name? Brian. So, the most shocking part for me about the lecture was I tried to use it. Well, I hope I can guys help. The most shocking part to me was this concept of what we all do about course.
I tried to open up the starting with a pen and
disagrees.
because there was like a little bit.
That's the thing that is shocking the most from her. And then she went over
That was like
different things. We can send there's pros and the cons. So I took pictures so that probably help me a little bit more. You guys.
tough back.
She's great, by the way. We were talking also about, she was talking about the idea about this correlation about what we believe and expectations that the patient or the client has. And if we believe on that and we make believe on what we believe, the results tend to be always more positive. That if it comes to your patient or the client comes to you and tells you something about some kind of technique or technology, I would say, oh, that's funny, that's important. Pretty much is what you believe that it has an effect on us, on whether we have a positive result or not, right? Yeah, I have any questions. I wasn't expecting to have to explain someone pretty much.
He just melts it.
Basically, families of different kind of, I think that was a great thing. So the typical, the facet, joint, the piece, and see families of the methodology to follow, what not to do, kind of at the next time related to each one of the most typical situations that we can find with patients or clients with muscle related.
There must be a susceptibility to get disc herniation.
She was talking about the concept usually this is that this injury want to avoid flexion with the client.
The stronger you make your back, the better.
Maybe you want to avoid extension. Sometimes that also helps to what kind of choice to do with the
like how many disc herniations?
So what you have with facet.
If you got a disc holder one segment, you probably have one partially.
That may be a bad thing for them.
Probably lost most of the
And they might feel better with some flexion movements.
Just 2 more minutes.
So you're
2 more
less
minutes.
likely to ever get a herniation.
It's never seen that first.
Yeah, it's just dry as that. Was his like shoulder or central? Shoulder symptoms or central? What? But did he previously have?
Pretty much
like if you have
most of the
motor, I can
80% of
understand
the
that.
clients they can complain about back pain usually are those where it's all face facet related, wrist related, or it's joint related. Most of the time these are the big majority of clients that they
Does he have back pain?
He'll sometimes say he'll feel his back, and that's just like
Yeah.
I feel my back every day.
like we just did like power press.
Two things that she didn't talk about it that was asked at the end of the session was the more posture, how affects the pain. She was
So
talk
he's
about
never had a muscle
Then I asked
working.
her about feet, dysfunction and back pain, and she also wants to talk about it. So I think so she wants to talk about the fascia release, because that's very related to L4
Imagine you could
and
hurt your
L1
disc.
dysfunction. So what you have in this kind of dysfunction is vertebrae segments, usually you have
Baby
kind of
could
issue
hurt their
with
disc. It's not
the
even.
fascia release. So I think that's why she don't go with all these.
Yeah, they were talking about that yesterday with Kevin Flores. Mike Boyle said
Right.
All right, Drew.
Tennis ball and all of that, right?
Just make him grow
this
for
kind
an
of
hour and a half.
spots.
Yeah.
They're saying that those that
Must have had some serious
All right, crew.
Especially the lower.
We shall wrap it up. You can stay where you are for now. And we're going to come to those questions in just a few minutes. So just to kind of wrap up, hopefully, a few key points that the people within your group did. So for me, I think the things I wanted you to come out of that lecture with were a few things. One, we first went over a lot of the anatomical and patho-anatomical reasons why people have back pain. And typically, based on the numbers and based on the literature, there's going to be 3 reasons why your clients have back pain. They're either going to have an irritated joint in their lumbar spine, they're going to have an irritated disc in their lumbar spine, or they're gonna have some SI joint pain. And actually the fourth reason is gonna be what we call non-specific low back pain, which means for no pathoanatomical reason at all, you have back pain. Like, we might as well have named it, we have no idea why you have back pain, because that's what non-specific low back pain means. So those are the top 4 reasons why people are probably coming to you with back pain. And have you heard any of your clients or patients say, yeah, I've got a facet joint issue in my back, or I have arthritis in my back? Who's heard that? Okay, who's heard I have a herniated disc in my back? Everyone, okay. All right, so those are the top 4 reasons why you're gonna see those things. So while there are pathoanatomical reasons why people have pain, there are non-pathoanatomical reasons why people have back pain as well, which is why there's that whole category of non-specific low back pain. And non-specific chronic low back pain, pain that's been around for a while, based on physiology, when you think about stages of healing, you've got acute, subacute, chronic. Acute is typically anywhere from 3 to 7 days, depending on the person's physiology, how hydrated they are, do they use tobacco, what's their circulatory system like, right? People who smoke and don't have, if they've got diabetes, circulation maybe isn't great, lots of different reasons why circulation might not be fantastic. They may stay in an acute state of pain for a bit longer than someone who is a lot younger with none of those comorbidities, right? Those people may only be in an acute state of pain for 3 days. Think about when you sprain your ankle when you're 10, right? Who's got kids in here, right? They sprain their ankle one day and you're like, I've been in the hospital for a week and a half with that, and the next day they're up and running around, right? So when you're younger, you don't have a lot of those comorbidities, you don't stay in a state of inflammation as long. As you get older, toxins, all those things build up, we stay in an inflammatory state for a little bit. Subacute, we start to move, our physiology begins to change, and that's gonna last maybe up to 14 days, and then we kind of get into a chronic stage of tissue healing. Those things are not necessarily the same as when we call somebody in a state of chronic pain. Pain is not all created equal. Pain can be because I put my hand on a hot stove and the nociceptors in my hand, the pain nerves go to my central nervous system and say, hey, you've put your hand on a hot stove that is burning my flesh, and it sends a message back down that says remove your hand from that, right? So that's what we call nociceptive pain. When you step on a tap, you hurt yourself, that's nociceptive pain. There's a stimulus and you feel pain. That's one reason why people are in pain. People can be in pain because of the inflammation as well. You step off a curb, you sprain your ankle, it swells up, it hurts. Because there's more fluid there, there's chemicals there that are irritating you. So that's an inflammatory state of pain. Those things are really easy to deal with. You remove the offending stimulus, things tend to get better. But then you've got neurological pain, like I'm having right now in my sciatic nerve, when there's a little bit of change in the nerve and you might get some referred pain because that nerve is irritated. That's a little harder to deal with. And then you've got nociplastic changes in pain, which is what we used to call chronic pain, but now the new term is nociplastic pain, because chronic implies time, whereas some people go into a nociplastic state of pain pretty quickly. Like I had one of the NFL guys, he took a bad hit and it hurt his back. And he came in the next morning and I said, how'd you sleep? And he said, like crap. And I said, yeah, I figured. He's like, yeah, I couldn't stand the sheets on my back. He's like, I couldn't have a t-shirt on and the sheets were killing me. Well, we know sheets aren't a noxious thing, right? His peripheral system there was a misinterpretation between what he was feeling and what his nervous system was interpreting. So that chronic or nociplastic pain can be really confusing. But we do have this term that's still out there called chronic pain, which means people that have been in pain for a really long period of time. Do you have patients who have been in chronic pain? Yeah, okay. That can be really hard to deal with, right? So a couple things from there. For your chronic pain patients, You have those patients that no matter what you ask of them, they always have pain. How does that feel? It doesn't feel good. How does that feel? It doesn't feel good. What do you feel with that? Oh, I feel pain with this movement, I feel pain here. Right? People who are in true chronic states of pain, you need to stop asking them how they feel. Because it's never going to feel good. It's never going to feel good. They're always going to tell you that it doesn't feel good. So I'm not telling you to not be empathetic, right? There's a massive difference between not asking somebody constantly how they feel and not being empathetic. I need you to be empathetic, but don't constantly ask your chronic pain patients how they feel, especially from a back pain perspective. And I can be guilty of that. Every time I give somebody an exercise, how does that feel? Oh, it feels good. Okay, well, what am I gonna, well, no, that feels like crap. Okay, we'll keep doing it, because I don't have another exercise plan, right? So, we have to be careful. We have to ask our chronic pain patients, especially low back patients, very objective questions. How did you sleep last night? Not great. How come? I just couldn't get comfortable. What position were you sleeping in? Now you go down the path of, can I help you with a better sleep position? Did you have a pillow underneath your knees? Did you have a pillow between your knees if you were on your side? Can you put a pillow underneath your knees if you're on your back? Did you try some of those breathing exercises we talked about? Did you put your phone away? Now you're giving them objective things to hang on to. What did you eat for breakfast this morning? Oh, I didn't eat breakfast. All right, you're not glad we talked about this. You gotta eat breakfast in the morning before you get, right? Now you're doing those things, right? So I'm not saying don't ask them questions. I'm saying don't keep asking them about their pain. They're never going to feel good. If it's hurt for 20 years, chances are it's gonna hurt today. So ask them more objective questions that can begin to get them focused on something objective. Ask them questions that can get them focused on something other than their pain. People in chronic pain and with chronic low back pain, they've been so focused on their pain, it's all they can think about. Get them thinking about something else. Because those people with chronic specific, non-specific low back pain, those people need something else to hang on to. So, again, we've got pathoanatomical reasons why people have pain. We have non-pathoanatomical reasons why people have pain from a chronic state. And those people, we have to give other things to do. So one of the things that I like to do are some of these breathing things and some of these, I'm going to call it kind of stacking stuff. So hopefully there's one or two extra little rock mats. Go ahead and take your shoes off for me. If you've got a rock mat, go ahead and just stand on it. If you don't, maybe someone will share with you. You can kind of fit 2 people on a mat. And we're not going to do anything exciting other than stand on it. So don't be too worried about what you're going to have to do with a partner that you don't know. You're just going to stand. And maybe move around a little bit. You'll kind of notice I love these mats, you guys. These mats should be not here by the end of the day. You all should take home one of these mats. I give one of these mats to all of my back pain patients. When we look, we talked about, and I'm going to kind of clear up that question too, because if it was confusing for one, it was probably confusing for others. We talked about how with low back pain, in low back pain, the low back anatomically was not made to rotate. I don't really like standing on the stage when I'm done, just so you guys can all see me. Wow. All right, so the low back from an anatomical perspective, the facets are in this direction. They are in the sagittal plane, which makes the lumbar spine really good for flexion and extension. The thoracic spine, the facet joints are in the frontal plane, which makes the thoracic spine really good for side bending. The facet joints in the cervical spine are in the transverse plane, and that makes the neck really good for rotating. So when you put those 3 things together, the shape of the cervical spine, the shape of the the shape of the cervical spine, the shape of the thoracic spine, and then the shape of the lumbar spine, you put those things together, you end up with really beautiful 3D motion at the spine. And we ended up doing the math on all the articulations in the spine, and there's 83 articulations of in the spine, 83 different joints in the spine. And we're doing spinal stabilization with our patients and our clients. If the spine was meant to be stable, it would be one big long bone, probably not 83 movable parts. So the back is made to move, and one of my biggest pet peeves with people when we're dealing with low back pain is how many of your back pain patients come into you and they say, or they've been told, or maybe you are even telling them, because I used to as well, I don't like you to bend forward. Your shoulders and your hips always have to stay in line. And so now we have our poor patients walking around like this because they're so afraid to move their spine, right? We create a fear avoidance behavior pattern within our back pain patients, and it's wrong. We can't do that. We have to educate our back pain patients that it is okay to move. Your spine is made up of 83 movable joints. If there was one thing your spine was made to do, it was made to move. Now, do I want your spine moving when you've got 300 pounds on a bar on your back? No, right? That's a different story. But as I'm moving throughout the world and I'm just doing things, of course, I'm meant to have 3D motion in my spine. But now, when we look specifically at the lumbar spine, those facet joints are in the sagittal plane. So the lumbar spine alone was made to do flexion and extension really well. It was not made to do rotation well, because the joint is just gonna like run into the other bone. There's nowhere for it to go. So when I don't have hip rotation, I need really good hip rotation to protect my back. Because rotation, right, when you think about your hip, you should have 45 degrees of external rotation in your hip and about 45 degrees of internal rotation in your hip. So you should have 90 degrees of hip rotation in your hip. When you look at the lumbar spine, you have about 2 degrees of rotation in each lumbar vertebrae, with the exception of L5S1, and there you have about 3 to 5 degrees. So you've got L1, you've got 2, L1, L2, L3, L4, so you've got 8 degrees of rotation. And then L5, we'll say you've got 3 to 5. So you've got somewhere around 8, 9, 10, 11, 12. We'll say you have 12 degrees of rotation at your lumbar spine compared to 90 degrees of rotation at your hip. If you needed to rotate, where do you want to get it from? Your hip, right? So that's why hip rotation is going to be key for your low back pain patients, as well as thoracic mobility. Because again, you've got about 2 degrees at every thoracic spine. So you've got 12 vertebrae there. So you've got 24 degrees in the thoracic spine from a rotation perspective. So you're going to get way more at your thoracic spine and at your hips than you do at your lumbar spine. So that's why we want to kind of protect that low back. We don't want to shear that L5S1. But when you look at where people have back pain, typically they're going to have problems at L4, L5, L5S1, because that's at the very bottom of our spine, and that's where people typically have herniated discs. Does anyone have had patients or have an L4, L5S1 issue? You've heard those numbers and letters together before, right? Okay. Guess what the bottom of your foot is innervated by? What nerves innervate the bottom of your foot? If you had to guess. L4, L5S1. That's exactly right. So L4, L5S1. So my patients with low back pain get this mat. And they get this mat and they put it in their bathroom. They put it in their kitchen. They stand and they just stand on it, they brush their teeth, they do their makeup, they do their hair, they do their dishes, they do whatever they want to, if it's, they do whatever. They literally just stand on it. You can watch TV, I don't really care, but your job is to move along these little nubs. Because if I can stimulate L4, L5S1 at the bottom of your foot and get that information going to those spinal segments and change, input dictates output. We like to be comfortable with the musculoskeletal system because we are strength coaches and we are physical therapists and athletic trainers and chiros and whatever other way we want to define ourselves in this room. So we like muscles and we like bones. But that's not what we're, we're made up of those things, but this is a sensory motor system. It is a neurological system, and we have to pay attention to the neurology of things because input dictates output. Every single time, input dictates output. And so if I change the input into a system, my output is going to be better, or it's going to be different. Not necessarily better, it's going to be different. So if I simply stimulate the nerves on the bottom of my foot, L4, L5, S1, this is going to send different signals up to L4, L5, S1 and change the input, which means it changes the output. Anything that is innervated by those things, L4, L5, S1. So my anterior tibialis, which is very painful on me when I sit for a long period of time. My gastroc, my calf, my hamstrings, my gluteal musculature. All those things that I'm trying to activate with mini bands and all of that stuff, still not a problem. I love doing that stuff. I'll have them do mini band work on here barefoot. Let's activate those glutes. Because L4, L5, S1 innervates all of those muscles. So now I'm just driving the neurology of it more. So having them stand on this rock mat while they're doing some of those mini band walks, instead of having them go 10 feet down the road, who's got space? Nobody has space anymore. Space is expensive, right? So just have them work on this mat. 2 out, 2 in. Perfect. Let's do some glute activation because now I'm stimulating L4, L5, S1 in the bottom of my foot, and I'm asking those muscles to work. So super, super simple. And if I don't have a rock mat, which you all will by the end of the day, so we're not worried about that. But if you didn't have a rock mat, you would take a spiky ball. That's the other thing I do. So I don't know if we have any spiky balls. I looked for some, I didn't see any. But if we had like a ball that's got like spikes on it, and I just have them roll out the bottom of their foot. That's the first thing they do in the morning before they even get out of bed. You sit up out of bed, the ball is right there, they roll their bottom of the foot for a few minutes, stimulate L4, L5, S1, wake that thing up, and then get going. Those first steps can sometimes be a lot less painful for them. If your patients are waking up or your clients are waking up stiff with low back pain, easy foot stimulation in the bottom of their foot. It's the simplest trick. I mean, I know this is a super boring lab. It will be life-altering to your low back pain patients. Life-altering.
So do you have your patients doing some core stability standing on it?
Yeah, you can. Yeah, you absolutely can. You can have them do their mini band work, you can have them do whatever their dead bug work or, you know, any of their plank stuff is fine. But the big thing is I like to do standing stuff on it because I'm stimulating that L4, L5. So any of their balance work that you wanted them to do, really, really great because they're trying to find. Also, it's really great for any of your osteoarthritic or anything like that. Because when people fall, think about your elderly clients, from a fall risk, people don't fall. We like to put people on unstable surfaces, right? Let's work on balance and put them on a Bosu ball. Nothing against Bosu balls, we like those too. Or we put them on the Blue Arex pads. Nothing against those are great. But I mean, unless you live in California, with the threat of an earthquake being a real possibility, chances are the floor is not going to move underneath you, right? Why you're going to fall or why you're going to trip is because of an uneven surface, right? Even people are like, well, I work in basketball, the surface is not uneven. Sure it is. When do guys sprain their ankles? When they jump up and they come down and they land on somebody else's foot. Right, so people get hurt on uneven surfaces. They don't get hurt on unstable surfaces. And yet, from our training perspective, we put people on unstable surfaces all the time. Doesn't make any sense. I would put someone on uneven surfaces and do their balance training and do whatever other things you want to do. I use this map all the time. Even forget my back pain patients. Just by introducing uneven surfaces. Uneven surfaces are what it's about. Sound good? So, I know, super simple lab. All right, so on top of that, from a postural perspective, we didn't get to go over this in class yet either. So, I want you to kind of think about, we're gonna start at the foot. I don't really care if you're flat-footed or if you have super high arches, it doesn't matter. Your shape is your shape. We're not going to change your shape, so it doesn't really matter. The thing I care about is, can you change your shape if you want to? to something called the dynamic systems theory. Dynamic systems theory states that the organism is going to do a task based on the health of the organism and the environment in which it's asking it to be performed. So the organism is me as a human. The degrees of freedom I have to move is my window of pain-free movement, and the environment in which I do a task is something. And then I'm gonna change my motor control and my movement pattern based on that. Okay, so if I have, everybody, I'm gonna ask you to go ahead, I want you to touch your finger to your nose. Okay, look around at your friends. Okay, everybody did this, right? Nobody did this, right? Because that's not the most efficient way for your nervous system to touch its finger to your nose. Your nervous system's always going to choose the most efficient path possible. Now, imagine that the hand or the finger that you used, that arm is in a cast. And now I ask you to touch your finger to your nose. I'm like, all right, well, I either gotta use my other arm or I gotta figure out how to get my face down there, right? You gotta figure out a different way. So that the degrees of freedom, the health of the organism matters how you do the task. Right, do we have any runners in here? Who's a runner? Okay, does anyone run a marathon or just a race, 5K, anything? Okay, have you run a 5K in 30-degree weather and 100-degree weather? Yeah, are your times exactly the same? No, right? Because your environment changes how you execute that task, right? Running in extreme cold and running in extreme heat, it's still the same 26 point something ridiculous miles. It's still the same human, it's just a different environment. So the environment changes your task, right? So we coach our clients to do this perfect movement all the time, when really it doesn't matter because the nervous system's going to select an efficient pattern. So I want you to be able to move into and out of things. So the thing I start with a lot of times with my back pain patients is just looking at their feet and having them explore, and go ahead and just do this for me, explore rolling to the side of your foot and rolling to the inside of your foot. That's going to make your knees kind of come together when you're on the medial side of your foot. That's going to make your knees come out when you roll to the outer part of your foot. And just sort of exploring that. Can you do that? Can you not do that? If you can't do that, do you feel a stretch somewhere? Is there pain? Maybe you do have a restriction that I as a physical therapist might want to go in and explore. Maybe you've got a limitation in your foot. Maybe you've got a limitation at your knee, because you can see how much rotation your tibia is getting as well, right? Can we feel that? Can we feel how much your hips are rotating? So maybe you've got a limitation in your hip if you can't do this. So this can kind of start to take me down an interesting path. But once I have them do that, then I tell them to just sort of find somewhere in the middle, whatever the middle means to you, where you just feel like the pressure is balanced, in to out to front to back. I'm not going to check it. We don't have force plates. Doesn't really matter. I just want them to find where they feel like their neutral is. And we're just going to kind of explore that space for a minute. Once they find that, I come up to their pelvis. Because, I mean, sometimes you got, my linemen, I can't even imitate how some of my linemen look, right? Like they've got that big old arched back. Whereas me, I'm super flat back. That's why I don't have booty. Now you're all looking at my butt, which that's not what I meant to do. But, right? Because I'm super flat back. Right? So your clients that are kind of super flat back versus your clients that are super lordotic. So, once we kind of find that neutral in their foot, now I want them to explore their end range. Go ahead and anteriorly tilt and posteriorly tilt. Now you might have to take them down to the ground so they have feedback, right? That might be where you start with this, where they have feedback with the ground to know what an arched back feels like versus a flat back. What does all of that feel like to you? Explore that range of motion. And then once you find that, find somewhere in the middle. Somewhere where you're not hanging on your joints in the back, and somewhere where you're not hanging on your ligaments in the front. Find somewhere in the middle. Whatever middle means to you.
What's the ideal range?
That's a good question. So his question was, what's the ideal range of motion? All I know is more than I have. But I don't know the degrees. I'm sure it's in a book somewhere. I just don't know it. But they should be able to do it. And I'm really limited in an anterior tilt, but I know I have some pathoanatomical changes in my low back that are making that difficult for me to do, that I need a little bit of external manual help with, and that's why I can't do it. But yeah, there is an ideal range. I don't know what it is though. So just kind of find that middle. Yes.
Are you having them or doing them at all with what to do with their knees? Because some people will instantly bend the knees so that they can reach that greater
Yes.
range.
Yeah. So the question is, do I cue them with their knees? Not at first, right? Like I just want people to explore their movement, right? Like we don't yell at our 18-month-old to, you know, squat better. Like he just sort of does it, right? So same thing here. Like I'm just kind of asking them to explore their movement. But you're right. If they're kind of doing one of these things because they don't really know how to move, that's when I would lay them down on their back. And I would say, okay, we're having, let's see if we can take this down a notch. Just come on our back. I want you to, I put my hand underneath their lumbar spine. I say, smush my hand. And now I want you to come off my hand, smush my hand. Right, so I have them try to explore that motion, see if they can get it there, and then see, okay, now I want you to stand up again, and I go back to their feet. Okay, let's find that forward, backward, side to side. Let's find our center on our feet. Now let's try that again. So a lot of times once they get it, they'll get it, instead of like cueing them at their knees. So yeah, so that's a really good question too on cueing, right? Because we can just I can overly verbally try to cue people out of stuff. If you put them in positions where they don't have a choice, it's a lot easier. So that's why I'll just get them down on the ground. So you've got your center for your feet. You've got your center for your pelvis, okay? Now, we kind of have to find our center for our ribs. So now, let's flare out our ribs, stick out our chest, pull our ribs back. And I may have them do this with their breath. So I may say, take a big inhale, and that really opens up their chest, and blow out as much air as possible. Okay, take in a big breath, and their chest may kind of come out and blow out as much air as possible. When they kind of feel those ribs going. So that might be a cue that I use if they can't really understand. I have them put their hands maybe on their lower ribs and have them flare out their ribs towards their chest towards me, press towards their thumb, out towards their fingers, towards their thumb. You might just need some different cues to get them from a rib cage perspective, but I have them explore that. So they've got their center on their foot, they've got their center on their pelvis, they've got their center on their rib cage. Now they've got to get a center of their head. So their head, we're going to just kind of tuck in like a turtle, and we're going to jut out, just like a turtle. Jut in like a turtle, and then jut out like a turtle. And I want them to find, again, some type of middle there, where they're not all the way to the end, but they're not all the way out. Because when we think about people's postures, how often are they here, right, with the double chin hanging on their ligaments, ribs are back, or are they here, head jutted out, supralordotic, hips are essentially flexed, and feet are kind of flat, right? This is what Vladimir Janda described as upper and lower cross syndromes, if that sounds familiar, right? So I'm just going to have them explore that head jutting and back. Find somewhere in the middle. Now, yep, go ahead.
How for individuals who can kyphotic?
Yeah, especially as people get older, they're going to be really kyphotic because they're starting to get structural changes in their T-spine. That's why if we can prevent that from happening, that is more ideal. Because if they have structural changes, a lot of times our older patients, they begin to develop osteopenia. So those vertebral bodies that we showed it, and from an anatomy perspective in the front, they start to become like a wedge instead of like a cylinder. And so the shape of their bone actually begins to change, and now they're stuck in this position. So that's why, again, I explore their range of motion. Because a little old lady who's kind of all rounded and kyphotic, her range of motion might be this. Right? It might not be a lot compared to what we're doing. So explore their range of motion. Yeah. And so now what we have, if we've got those feet are solid, and I did this all on the mat, their feet are solid, their pelvis is solid, their ribs are solid, their head's in a more neutral position. This is their neutral spine. This is when things are centrated. We all talk about our diaphragm and the shape of our diaphragm, diaphragmatic breathing, and all these breathing things are really important because, and we'll get to some of the breathing stuff here in a second, but we've got that diaphragm and we know the shape of that diaphragm. Well, if you look at the pelvis, you just flip that diaphragm, the pelvis is just an upside down diaphragm. And you have a little canister at your abdominals. So now I've got this top part of the canister stacked on this top of the canister. That's centration. Now I can load. I can have a kettlebell and do different, like now I can load. I can do different things. I can put a bar on my back. I can do whatever I want because I am in neutral with those diaphragms lined up. If you go down your arch of your foot and we dissect out your foot has a diaphragm in it. It should look like that. So now I've got the diaphragm of my foot normalized. If you look and dissect out the tongue, your tongue isn't flat. Your tongue does not look like this. If you chop your face in half and look at your tongue is like this. It's in the shape of your diaphragm. So now I've got my diaphragm of my tongue stacked on my actual diaphragm, stacked on my opposite upside down diaphragm of my pelvic floor, stacked on the diaphragm of my foot. Man, now I can load. Now I can do whatever you want me to do. And with my back pain patients, and now I've got a system that can load. I've got the bottom of my foot stimulated. Now I can go grab a kettlebell and do farmer's walks. Try to maintain all of that centration with my unilateral kettlebell walks. I don't like to do bilateral with my back pain patients. I like to do unilateral, where they're just carrying one heavy kettle, as heavy as they can go, heavy kettlebell on that one side, because it's going to want to pull them here and they got to fight it. That's some great core stability for my back pain patients. I do both sides all the time. Because they're going to be strong, they're going to feel stronger on one side than on the other. So you can always, if it's a massive difference, you can always go I go 10 yards on the right and 2 sets of 10 yards on the left, right? I can always do a set on the left, walk it back on the right, walk it back down on the left. I can always do an extra set on that weaker side. I'm a big believer in training that unilaterally, but both sides, and then just altering my sets and reps if I have a weaker side. But I like to train both. But now I can get them to load, which is good, and then do other things. So that's kind of where I start with my back pain patients, which probably isn't typical, right? I used to start my back pain patients on their back, right? Doing dead bugs and sort of those sorts of things. For me, this is my level 1 core stability. Let's get here because this is you carrying groceries. This is you carrying your suitcase. This is you wanting to train. This is you lugging your kid, whatever it may be. Right? Well, life isn't laying down on our backs. And the one thing I want to do with my low back pain patients is get them out of a fear avoidance behavior pattern. We have put the fear of God into our back pain patients. Don't move, your back will explode. If your shoulders even misalign from your pelvis, right? And then we wonder why they're afraid to move. So that was a really long summary of the talk to say, we've got our patho-anatomical reasons and non-patho-anatomical reasons for back pain. What the literature tells us, what the literature tells us is that people need to move. If people move, they have less back pain. And people who have back pain, the more they move, the less back pain they have. So the literature tells us that movement is good for people with back pain, and it's our responsibility to educate them to that.
So how do
Yeah.
And stretching also, a twist, and now they're saying, don't do the twist, so then, but then I hear, yeah, it's okay, do the thoracic, so you teach
Yeah. So we make some modifications. So let's all go down onto our hands and knees for me. So if I want to see how much somebody is rotating at their thoracic spine, I get them as much as possible into like a child's pose position. Okay. So now a lot of your clients may not be able to get into a full child's pose. So put foam roll or roll up a pad, put something underneath them, get to their end range. Right? Their end range doesn't have to be the end range. Does that make sense? Get to their end range. Ankle plantar flexion, knee flexion, hip flexion, lumbar spine flexion. Now what you're going to do is you're going to get that left elbow towards the center of your body as much as you can. Your right hand is going to go behind your neck. You are going to lift your right elbow, look underneath your armpit, and lift your right elbow towards the sky. And then bring that elbow back to the ground. Try that again. Look underneath your armpit, right elbow to the sky, come on back. Now, what I want you to do is stay on that side. Come up into quadruped for me, or I should say triped, because your left hand is down, your right hand is still behind your head. Now look underneath your armpit and raise your right arm to the sky and back down. How much more motion do you have there? You have tons more motion in that position, right? Go back down into your end range child's pose. Try that same motion to the right again. And just compare the motion you have when you are in this end range of lumbar flexion to being a quadruped. You have way more. So if I don't want them to compensate at their lumbar spine, I have to take their lumbar spine out of it. And I have to get them in their end range of motion and work on T-spine rotation here. So I can do that here and protect the low back. I can do that on their side. We all like to do this like 90-90 stretch, right? I call it 110-90 stretch. Because I want, so go ahead, everybody lay on your right side for me. In whatever, let's not even overcoach it. Just lay on your right side. And I just want you to open up like you would. And explore that range of motion that you have. Very good. Oh, I should take a picture as well. Okay, good job. All right, now what I want you to do is I want you to bring your knees and I want you to bring them toward your chest as much as possible. Your knees should be higher than your hips. If your knees are not higher than your hips, you're not doing what I want you to do. So knees should be higher than your hips. Now try that exercise again. Rotate back. You can take your bottom hand and put it on top of your knee to help stabilize so you don't cheat. And open up with that top. Do you have different range of motion? You should have less range of motion with your knees above your hips. Because I've taken your lumbar spine out of it. I've taken away your compensation pattern. Is anybody in the room a chiropractor? Anyone? I can't tell because everybody's hands are going. All right, go ahead and sit up. Anyone in the room a chiropractor? We have no chiropractors? That's so sad. Has anyone been to a chiropractor? Okay. Has anyone had their low back manipulated? What does the chiropractor do? They get you in this position, right? They get you in this position. They get this knee all the way up here, and then they rotate you and they crack your right? They don't do it with your legs down here. Why? They have to flex you to the level that they want to manipulate. That's a difference between a good manipulator and a not good manipulator. People who are just like, boop, you know, it's like a non-specific manipulation, right? So the more you flex that lumbar spine, you flex up to the level that you want to manipulate because you lock out everything underneath it, and then you can mobilize the segments above. So I don't want you to call it as a really long answer to say, if I don't want you, right? And then the other way we can do that too is just in standing, right? So we've got on our belly, on our side. If, depending on the person, I can get them, if I'm here, and I have them, well, I'll go this way, and I open up here, I've got a lot of motion. But if I really flex my hip, now I've got less motion. If I really flex my hip, now I really have less motion, right? But down here, I can see the back room, but when I'm way up here, I mean, I barely, totally different. So you gotta lock out, take out their lumbar spine so they don't cheat.
So if you're in that bottom step, because I'm training you now with incline, and they can't do it high, how do you know, put their hand in the lumbar and make sure they're not compensating, or?
Yeah, I might just use a wall to help stabilize, right? So I might just take some of those steps over and put something here to kind of, so they're a little bit more supported here, and just walk. You can kind of see if they're overcompensating, if their knee starts to come away, right? Like their knee should stay parallel to the wall. The minute their knee starts to not be parallel to the wall, now they're compensating. So you can use something like that, if that's helpful. But yep, of course. Okay, so that brings us into the question. What time is it? What time do we go to? We have 15 more minutes? How are you going to get through your questions in 15 minutes? Okay. Was that helpful? Is that okay? Okay, let's answer it. So you guys all wrote down some questions. Yes.
So, I spoke, you just did this one. If they sit all the way, if they sit all the way back, say for a healthy back patient trying to get, a healthy client just trying to get some movement in there, is that okay to put them up a notch on their hands, or would you rather still see it work from that more closely?
Right, so the question is from a not back pain patient perspective, I still teach it that way because I don't want to feed that compensation.
Would you ever work up to the hands, or not really?
Not if I'm doing thoracic mobility, that like a thoracic rotation.
Okay.
Which if anyone else feels like they need to rotate to the left, I feel really awkward, right? Because we did all of those going to the right. I kind of feel like I need a little bit. Yeah, because it's totally different, right? Like my range of motion here when I'm down here is not very good. And when I'm up here, it's super great.
You
So
sit all the way back.
yeah, all the way, as much as they can. Their end range. So if you have to put, if they've got meniscal tears in their knee or knee joint degeneration, they're not going to be able to get that much knee flexion. So just put a pillow between their heels and their booty or something like that. But yeah, I teach it that way for everybody. Healthy, not healthy, back pain, not back pain. That's how I
So you
teach
like
them.
those three that you just showed?
Yeah, for T-spine mobility.
You hit all of them there.
I will. Some of it will depend on the person. Like some of your elderly patients aren't going to be able to get down on the ground unless you have like a mat or something that you can get them on. So you may want to do standing with them. Some of your other people, I like getting people on and off the ground. That's important. And if my elderly patients can get on and off the ground, it's important. Have you guys seen that study? It came out years ago that shows that people can't get up off the ground by themselves without having to hold on to an external implement. Their mortality rate is significant in the next 5 years. So even your elderly, my poor mother, I make her get up and down off the floor without holding it. She's like, why am I doing this? I'm like, because I need to know. Or 5 more years ago. So yeah, it's important for them to get up and off the ground. So sometimes I'll do that. It just kind of depends on the situation. If I'm outside on the field, the guy doesn't want to get down on the wet grass, we'll do standing. So she's asking me about Sherman's disease. I don't know what that is. So- Like a bony degeneration? Oh, it's like a Schmorl's node back thing. That blows. Yeah, I would not. Anyone who has stuff like that, I wouldn't emphasize more motion for them. I would emphasize more stability probably with those people. Yeah. Yeah, more hip strengthening and more stability. And that was the other kind of summary from what we talked about earlier, is that when we start to look at what types of exercise for low back pain is good, the thing that the research is showing us over and over and over again is we don't have to do a whole heck of a lot. In fact, the WHO, right, so they look at metabolic equivalents of training, and so the WHO recommends 600 METs per week of exercise, which is about 75 minutes of vigorous exercise per week, or 150 minutes of moderate exercise per week. And what we're seeing with low back pain patients is they need around 150 to 300 METs per week to decrease their back pain. So they literally have to move half the amount that the World Health Organization recommends a human to move, which is great. That doesn't mean we need our back pain patients running marathons. It just means we need our back patients to move a little bit. They just can't be totally sedentary. We have to have them move. And from an education, like, I'm sure you came to this thinking, I'm gonna get 85 new exercises for my back pain patients. If all you get from this lab is stimulating the bottom of your back pain patient's foot with either a rock mat or a spiky ball, and educating them that movement is okay, any type of movement, and the research will show us that Pilates is the #1 best thing that they can do. So yay, any Pilates instructors in the room, you just got into yourselves like a great marketing tool. Pilates is one of the best things that they can do. Aquatic therapy is a great thing for them to do as well. And then any other type of neuromuscular re-education. So whatever that means to you. If you want to do dead bugs with people, that's great, that's fine. Glute bridges, all of those sorts of things. Walk, Palloff presses, walking, stabilizing, all of those things are great. The research is showing it really doesn't matter what you do. How wonderful is that? I mean, that makes me relieved. It doesn't matter what you do with your client. Do whatever they like to do. That's the other thing we talked about in there. We talked about that patient expectations matter. So there's some studies that show that when patients have the intervention that they think is going to make them better, it makes them better. And if we give them a different intervention, they don't get as better. So like literally with your back pain patients, all you have to do is ask them what they want to do and what they value, and then do that a little bit. You're welcome.
So,
I mean, like, we try to make back pain really complicated, and that's what I was hoping that I could do today, is like, make you not nervous about back pain. It's not as scary as it is. Back pain is scary, and I don't want it to be scary anymore.
I think this is pretty typical, but is it usually muscular? Like, when a client comes in first thing in the morning, complains about back pain, and it's also all that, and he starts working out, and feels better, and he feels good when he leaves. And then he comes back next time, same day.
Yeah.
Is that a typical muscular issue there, or?
Yeah, it could be from a lot of different things. So the question is like, right, we all have this with our back pain patients. They come in, they're really stiff in the morning, and then they move around, they feel better, they go away, they did great, and then it starts all over again. So typically when patients are, so these are just kind of presentations. Oftentimes, people that are worse in the morning and get better with movement and get better throughout the day, a lot of times they have some disc issues, because when we lay down, the way our discs get nourishment is they imbibe fluid. And so they imbibe fluid overnight as we're laying down. And so our discs are a little bit bigger in the morning. And then they stand up, and gravity and walking and moving compresses those those discs so the fluid comes out. So if you have a herniated disc or some type of derangement in your disc, that bulge is actually bigger in the morning, so you feel stiff and miserable and might have more pain in the morning until gravity takes over and we can kind of get some of that fluid out and that actual derangement in the disc is smaller. So, a lot of times with those people, what I try to do is just work with their sleeping position. So that's the other thing with my back pain patients, because back pain a lot of times is worse in the morning. So can we find a position where they have a foam roll covered in, you know, some type of a yoga mat or a pillow or something, so they can have their knees a little bit bent. If they've got numbness and tingling down one leg, a lot of times I'll just have them put the pillow underneath that one leg, take the neural tension off of that one leg. So this leg can be straight, this leg is up on a pillow. Get some neural tension out of it. They wake up a lot of times feeling better. They brush their teeth, they go stand on this thing. Let's get some information into L4, L5, S1 while you're brushing your teeth in the morning, right out of the gate. This will help desensitize that pain. If they're a side sleeper, pillow between the knees, right? Because this, like I would never stand like that for 8 hours a day and wonder why my back hurts when I get up, right? But like we let our patients sleep like this all the time. So my back pain patients, pillows in between their knees so their pelvis is equal. So that way they're just in that more neutral position. So I help them try to find a strategy for sleep, if they can. But sleep is going to be tough, so if we can help them mitigate strategies, if they can't even make it to the bathroom because they have a hard time walking, their pain is so bad in the morning, spiky ball at their floor and have them stand at the bottom of the floor before they even stand up. Yeah. Okay, some other questions? Yeah, so she asked me specifically about SI joint dysfunction. So do a lot of your patients, and do you guys see some clients with SI joint dysfunction? Yeah, a few people. SI joint stuff can be tough because it doesn't, some people don't even believe in the SI joint, which is a funny thing. It's like saying you don't believe in gravity. Like it's there, you know it anatomically exists. But a lot of people don't think that it can be a pain generator. The joint capsule of your SI is innervated, so it can be a pain generator. And the way to treat SI joint stuff can be really complex, and at the end of the day, they say do all of these things, and then if it doesn't work, do the opposite of that. So like I've just like eliminated all my SI joint stuff, and I just do it one way, and then do it the other way, and see what other one works. So the thing with the SI joint is that it can move. The surface of your sacrum is like your knuckle, and the surface of your ilium is like your other knuckle. So it doesn't take much, especially in some of your postpartums, or in anyone who's had a car accident or slid into second base or third base. They get this hypermobility, and then it doesn't take much for it to do this. So again, it doesn't take much for that joint to do this. So you don't need a whole heck of a lot to just sort of kind of change some of those things around. But when things are like this, it can feel really bad, and when things are like this, it doesn't feel that bad at all. So a lot of times what I'll do, work with a healthcare practitioner that can kind of help evaluate a little bit, and I give people a lot of muscle energy techniques that they can sort of self-mobilize. Because if they are rotated in one way, a lot of times those people, if it kind of looks like they have a shorter leg on one side, a lot of times if you just use their muscles to bring them back a little bit, it just doesn't take much to get them back. So I do a lot of muscle energy techniques with those people. Yeah. Well, yeah. Well, have you had children? Not to be too personal. Some people, there might have just been trauma there. So a lot of times with people who have constantly, even with my guys, with my professional athletes, I get them an SI joint belt. They hate it, but they're so happy, and an SI joint belt works beautifully. So you get an SI joint belt, you can order them off of Amazon for $25, $30, maybe $40 or $50. They're not more expensive than that. You get an SI joint belt, you cinch that thing around your lower hips as tight as it can go, and you wear it 23 hours a day, all the time. You never not wear it. And if loosens up, you make it tighter. You do that for about 2 weeks and things tend to kind of stabilize. Yeah, you wear it all the time. And guys are amazed, it usually decreases their pain pretty quickly. So if I'm having somebody that's constantly having that, just go to an SI pill. Really easy.
Kind of piggybacking off what you asked about kids, I have a lot of clients pre-postnatal, and I noticed that few things, their pain, low back pain, or pain increases due to the elasticity of everything.
Yeah.
And hormonally and emotionally,
Yep.
what's going on when they are emotional, they amplify pain.
Yep.
But postnatal, I'm noticing that, what do you do to be able to help them the best post because the pelvic floor has shifted or is different?
Yeah.
Or, I've been sending my clients to pelvic floor therapists
Yeah.
first before working with them. to
Yes.
make sure that that's clear, but is there anything else protocol-wise that you do with folks?
Yeah, caveat, so the question's a lot about postpartum type stuff. I haven't worked with a female since like 2007. So I'm probably not the best person to ask that question for, but I work with a pelvic floor therapist. And a shocking, men actually also have pelvic floors, which I know you're like breaking news. So the pelvic floor knowledge is super important, and I've learned a lot from her on back pain for those reasons. And there's a lot of biofeedback type things you can do with especially postpartum women from a pelvic floor perspective, a lot of biofeedback stuff, a lot of internal weight type things that you can use in order to resistance train and all of those sorts of things, totally beyond my scope of practice, but I would work with a pelvic floor. I think you're doing exactly what you should be doing. Working with a pelvic floor therapist that can help coordinate and help guide your strength and conditioning type stuff. So I think that's fantastic. I know we didn't get to quite everybody's questions. I am not in, yes, we'll
Quick
go.
question. You didn't talk nothing about K, but one thing I see with my clients,
About what, I'm sorry, what?
about K, walking,
Oh, yeah.
why people, when they get older, they don't move their arms? Why they eliminate the arm swing? And how that affects lower back dysfunction?
Yeah, interesting.
I
So
have
he's
to
asking
remind
about
them
big.
to get the swing to help the hips.
Yeah, because yeah, that's a great question. So yeah, people need to have reciprocal movement with their arms, absolutely. So that's really difficult. There's some really interesting things, believe it or not, like from watches. Like I wear my Oura ring and my watch on my left hand, and so I think that I walk a little bit differently when I've got all, electromagnetic fields are a thing, and our body is one big massive electromagnetic field. And so a lot of times people will alter their arm movement on the side that they're wearing their Apple Watch or their Oura ring on. And so when they take those things off, they have a much more natural arm swing. Yeah, electromagnetic fields are a thing. So that would be the first place I would start, is see if they take those things off, does it automatically change? Because from an electromagnetic field perspective, it might completely change their gait. And then if not, it might be because of fear avoidance. Again, right, we have put, especially with our back pain patients, we have scared our back pain patients. We've scared them. So like they walk around like this because they don't want to introduce any rotation into their back. Because bad things, we've told them for years, bad things are going to happen. So we've got to, it's going to be habit breaking. And that's
But there's no mechanical or physiological issue or reason why people tend not to move their arms. I thought that maybe sometimes just to get them more balanced. I don't know.
No, it's usually a fear avoidance behavior thing. Unless there's some crazy stiffness within their lat fascia, which could be, but I mean that would take an enormous amount of densification in the fascia to limit their range of motion there. It's usually a mental fear avoidance thing that they've developed over time. Yeah. I know that probably wasn't the lab you were expecting, but I hope it's a realistic lab that says stimulate the bottom of your low back patient's feet with a rock mat or a spiking ball. Do any type of low level neuromuscular